Good morning, everybody. Welcome to Tyro Multidisciplinary Seminars. We unfortunately have a slight change in our schedule here due to sudden health issue for Dr. Busady, who has reassured us that she will circle back with us and give us an alternate date to discuss this very important randomized study that was conducted and published in Thyroid. We do have the great fortune of having Dr. Frances Worden to present an alternate lecture this morning that obviously related to thyroid cancer, and Dr. Margaret Brandwein, who you all know will be here and will challenge Dr. Worden with questions at the end of his lecture. Let me give you a little bit of background on Dr. Worden, who really should not require any sort of introduction. Dr. Worden has the unique personal history of having entered the field of medicine as a registered pharmacist before leaving the world of pharmacy and moving on to medical school, and ultimately also had completed a residency both in pediatrics as well as internal medicine, and then went on to do a fellowship in medical oncology and hematology at the University of Michigan, where following completion of that fellowship, he joined the faculty and has remained there ever since. He is a clinical investigator with special interest in both head and neck oncology, lung cancer, as well as a tremendous amount of work that he's done in thyroid malignancy. We appreciate Dr. Worden switching gears here to be the primary presenter. And so look forward to his presentation. Frank, how are you doing?
Good. Thanks so much, Mark. That was very kind. And thank you for having me. And I will do my best because I wasn't as prepared for this morning, but things do happen. So this is basically work that has been done internationally, as well as work we've done here some at Michigan, and it's kind of an overview of the treatment of thyroid cancers, primarily when they become refractory to iodine, and kind of where we've been, where we're now, and hopefully where we're moving in the future. These are my disclosures. So, as we all know, thyroid cancer, the differentiated thyroid cancers are the most common, papillary followed by follicular, and then a small number of undifferentiated, and then medullary representing about 1 to 2%, those that are sporadic as well as hereditary. So those of you who like classic literature like I do, all happy families are alike. So all papillary cancers are alike, but they're unalike in their own different way. And so it's important, and Margaret will tell us this too, that the presentation of some of these cancers can have various outcomes in terms of their propensity for metastatic disease or becoming BRAF. Positive or other genetic drivers that may lead to RAI refractoriness. What's important too, at the bottom of the slide noted here, is that about 50% of these papillary thyroid cancers can transform to more aggressive or undifferentiated thyroid cancers. In terms of follicular, it's the second most common type, as we mentioned, dissemination hematogenously, leading to a propensity for brain mets and a lot of bone mets with these cancers. And then the genetic RAS point mutations, which are more common with these cancers than with others. So as thyroid cancers are more well differentiated, we know they have the propensity to take up iodine. And when they become more poorly differentiated or take on these insular variants and then become undifferentiated, we're less likely to see any kind of iodine uptake. And this increasing aggressiveness has to do with the combination of these driver mutations in combination with TERT, P53, PIK3, and others. So this is kind of the high level view that I tell the fellows when they come to the clinic, that you may see a question on your boards about requiring surgical excision because most of these cancers are curable, and only about 4% of these folks will come to our clinic as medical oncologists, followed by radioactive iodine after thyroidectomy and neck dissection. And then watchful waiting with ultrasounds and thyroglobulin levels. If isolated mets pop up, we do treat bone brain mets with external beam radiation therapy, or SBRT, and then continue to watch these folks. And then eventually, a small number of them do become refractory to iodine, and then that leads for us to consider systemic therapy at some point. So I put this slide in here. This is one of my colleagues, Megan Haymarch. And what I have it in here for really is, I tell the medical oncologists that sometimes when people come to see us from the outside, I send them for radioactive iodine therapy. Because what she showed us is that there are low risk patients who actually probably are overtreated with radioactive iodine therapy, and some high risk patients who are undertreated. So I think that's important for us to really make sure that we know, kind of like Megan says, you almost get RAI based on your zip code. There isn't a lot of standard for this practice in some areas. So we really want to make sure we know that these patients are refractory to iodine before we consider systemic therapy or other modes of treatment. So what's important here is the definition of what patients are when we say they're iodine refractory. And again, about 4 to 5% of these differentiated cancers will develop incurable disease. So when you have at least one target lesion without any RAI uptake, progression following treatment with RAI, so within 6 months or so, you see thyroglobulin levels going up, you repeat scans, and there's no uptake. Or we usually say in our country that a cumulative RAI treatment dose of greater than 600 millicuries defines refractoriness to iodine. And again, it's blocking of the symporter, which no longer allows the flow of sodium out and then iodine into the cell, allowing us not to deliver the radiation like we would like to. So this is a paper I published a while back, and essentially the top part here of the schema is talking about what we just said with surgery, neck dissection followed by RAI, and then watchful waiting. And then when we really figure out those folks are refractory to iodine, the question comes in, when do we consider treating these folks? And I think people who have large volume disease, who are very symptomatic, are those who you should consider treatment, pretty much right away. On the flip side, people with small burdens of disease that aren't progressing very quickly are those we continue with observation. And then the question always comes in between the large volume that kind of is sitting there, not growing very quickly, or the small volume that's growing quickly. How do we judge when we consider starting treatment? So to help answer this question, we actually published a paper in 2022 to look to see, hopefully, when we know when to start people on tyrosine kinase inhibitors or other therapies. We couldn't establish that, but what we did find and did note was that the median time to symptomatic progression in 2 cohorts of patients, whether they were RAI refractory without any treatment. So we took those patients once they're refractory iodine and followed them until they became symptomatic. And the second cohort were actually on TKI therapy. And we found in both groups essentially that the time to symptomatic progression was about 55 months. So, 5 years in there, which is good news for our patients, because a lot of times people come in and say, how long am I going to live with this? And we have information to tell people. We weren't able to say when you were going to start treatment, because some people developed an isolated met in the bone that was treated with radiation. So that was symptomatic progression, but didn't require TKI therapy. So patients who were, these curves on the right, the Kaplan-Meier curves, weren't done for comparison purposes, but kind of done to overlay the curves to see where things fell out. Of course, people with therapy maybe were a little bit better in terms of progression-free survival, but essentially both groups were about identical. And what's important here too is this is a paper that we didn't get published yet, but it was when Lenvatinib and Sorafenib came out with their data to support the use of these TKIs, that Vandetanib was also looking at a phase 3 study. They had randomized phase 2 data supporting that Vandetanib did improve progression-free survival in differentiated thyroid cancers when they were refractory to iodine. But interestingly enough, this study, when it was done on a larger scale, was negative. And the question is, why was it negative? And when we did this sub-analysis of looking at the different data points, we found that the people with TSH suppression were not seen so much in the Lenvatinib, probably because the study was put together quickly. There wasn't, a lot of close monitoring. So what this is really telling us is that TSH suppression is important, and we can improve mortality even if we're just suppressing the TSH without, active treatment. So, and with treatment as well. So it's important for the ATA guidelines that we do suppress TSH to less than 0.1. So this is a slide of my family, kind of showing that where we've come from and where we're going. So I had more hair back then, was much younger, but my wife on the left shows us that back in the 70s, before we had adriamycin, it was the only drug we had to use, which was very ineffective for the treatment of these cancers. And then in the 2000s, become more active involvement with TKI therapies translated from other cancers and adopted into thyroid cancer. And then moving into the future, we now are looking at next generation sequencing as being very important for these refractory patients, as well as the potential use of immunotherapy and perhaps other agents. So the important point here is that once a patient develops refractoriness to iodine, we should look for driver mutations within the pathology. The endocrinologists and surgeons don't necessarily look up front when we're doing surgery because we don't actually know what to do with that data. But once we have an incurable state, it's important for us to understand the genetics behind these tumors. So what we can see here is that the most important target for these multi-kinase inhibitors is VEGF. And so Lenvatinib, sorafenib, and others act on this receptor amongst others. But it's important for us also to identify other potential driver mutations, because now we have new therapies, I think most of you are aware, that can help in the treatment of this disease. So this slide is important because we can see that these driver mutations exist amongst both papillary as well as follicular, and there is some overlap. The most common, as we mentioned before, is BRAF in papillary thyroid cancers. About 25% in papillary can show up with RET alterations. The point mutations are seen in medullary thyroid cancers, and the fusions are seen in the differentiated thyroid cancers. And then we can see RAS in both, PIK3 amplification primarily in follicular, and NTRK we can see in both follicular as well as the papillary thyroid cancers. Then a small number of patients will have high mutational burden, which may provide benefit from a checkpoint inhibitor. But the important point here is when ERAF, for example, or RAS combines with TERT promoter mutations, there's a robust predictive failure for RII. So the important point here too is that Dr. Giordano from our institution has shown that these mutations are mutually exclusive. So once we establish the driver mutation, we don't need to go back and necessarily look. Bypass mutations, could occur, but in general, these are mutations that are throughout the lifetime of the disease. So this is a time frame to see where we've come. Now we have so many different opportunities for patients where back early on we didn't so much. So this has actually helped us to make this disease more exciting to treat. So when I was a fellow and graduated, people would come in and they said, well, we're just going to watch your cancer, make you a little bit of radiation. And now we have opportunities for patients. So behind GIST tumors, we have actually the second most targetable amount of mutations and drugs available to treat these patients. So these are the landmark studies where the whole experience began. First with the Decision trial that Dr. Brose presented at ASCO, and then subsequently published, showing an improvement in progression-free survival over placebo. We don't have survival data because there was crossover allowed. And the response rates were around 12%. And then a year or so later, the SELECT trial. So Chamberlain and colleagues published an overall response rate around a little under 70%, and improvement 18 months over 3.6 months in progression-free survival. So this kind of put Lenvatinib on the table for patients who have differentiated thyroid cancers that are refractory to iodine. And important to note is that we had second-line data. This necessarily wasn't published, but presented at ASCO that shows that even patients who are treated with sorafenib or perhaps other TKIs and went on to get lenvatinib also had benefit over the placebo group. And then this was a subset analysis that we published showing that people who were older or greater than 65 actually had survival benefit or benefited from lenvatinib compared to the placebo. Interesting enough, I am also involved in a real world experience looking at the same age group, and we're seeing, very similar data. The explanation we've come up for this is that a lot of these people have comorbid states with cardiovascular disease, COPD, for example. And when they develop lung mets, for example, they are compromised because their other conditions aren't allowing them to breathe, for example, more effectively. If we treat these people and they respond nicely to the TKI therapy, it suggests that they're able to kind of cope better with their other comorbid states. So this actually is benefit and actually are beneficial for this group of patients. And it also suggests that we shouldn't be afraid to treat patients who are older. Importantly, too, Dr. Bros and colleagues, we were part of this and COVID came, so didn't have as many enrollments in our institution, but nonetheless, they showed that lenvatinib 24 milligrams should be the established starting dose. So in this study, they compared 24 to 18. Initially, they started with 14 and found that it was not providing any kind of benefit. So it was changed to 18 milligrams. And what we found is the response rates are higher at the higher dose. And really, if people are going to develop symptoms and side effects, they're going to get them whether they're 18 or 24. So their quality of life necessarily wasn't, compromised at the higher dose. So patients, for those of you who've used this drug, know that you can start once they develop side effects, then you can stop it and drop the dose. And eventually you're able to find a dose that people can go on and maintain. Again, back to our data from Riftos, you can see that a lot of these people can actually be maintained on this a medication in a dose that is established for them for long periods of time. So this was a real world experience that I published with some folks looking at insurance databases, and it kind of was all over the map in terms of the TKI therapies that were used. When lenvatinib and sorafenib came on the market, there was a shift towards using these medications. But nonetheless, there are still some people who have philosophies that perhaps cabozantinib or pazopanib, should be used in the front line. So, but now I think with this established data, we know that lenvatinib probably is the leader amongst these TKI therapies. And then the important data that came from this study, the Cosmic 311 study. So in this study, they put together two endpoints in order to have a positive study, either response rate or improvement in progression-free survival. And the study was actually stopped early because when patients in second line, so those who had failed TKI therapies up front, were treated either with placebo or with cabozantinib, they saw a vast improvement in progression-free survival with objective response rates that were 11% and then an updated analysis about 15% actually. So what's important here is that we do have a drug now or a hierarchy established after first line therapy. We can also see by the placebo curve there that this is a very aggressive form now that these patients have taken on after they've failed a first line therapy. So we can see the benefit with cabozantinib, and this is actually important because, like with other cancers, there have established hierarchies with renal cell carcinoma, for example. We really haven't had that in thyroid cancer until now. And this shows us that the patients who probably benefited the best were those who had been previously treated with sorafenib, probably because of the benefits of the response rates with and progression-free survivals with prior lenvatinib. But nonetheless, there was still improvement with both previous sorafenib and lenvatinib therapy when given cabozantinib. So, what other opportunities can come up outside of just targeting VEGF and multi receptors leading to higher toxicities, which we really haven't talked about here, but I think a lot of you who've used these drugs are very aware of the toxicities related to these multi-targeted kinase inhibitors. So now we have driver mutations who have drugs that are specific for those mutations. So the TRK fusions, the RET fusions, and perhaps the BRAF mutated cancers. And then in MTC, we have RET alteration. So responses, as it says at the bottom, can be dramatic and they can be sustained. So starting with BRAF, Marcia Bros published a study where with first and second line therapy with vemurafenib single agent showing median progression-free survival of 18 months versus 8.9 months in those who'd previously been treated. So suggesting there is potentially a benefit here with this drug, though the response rates are lower than that of Lenvatinib. So the question comes in, where do these particular agents come into play when we're thinking about treating folks who become symptomatic? And then this was the study that was supposed to have been presented today that we'll present at some other time by Naifa and colleagues. And what they did in this study was to randomize single agent dabrafenib to a combination of dabrafenib and trametinib. It was not powered to show a difference in progression-free survival, though it probably is a small trend toward a benefit in D plus T. But nonetheless, again, the progression-free survival rates are a little bit lower than we would see with the single agent Lenvatinib. They initially showed responses across the board for any patient who responded versus the standard recess criteria, which was later established. So the response rates are a little bit lower in the 30% with a single agent arm to 35% in the D plus T arm. Again, less than you'd see with the Lenvatinib, but nonetheless, there are objective responses here. This led to the FDA then leading to an approval for dabrafenib in combination with retinib for unresectable patients when therapies are not available. Interestingly, this was agnostic, so it's not just for thyroid cancer. The NCI studies that were conducted included thyroid cancer patients, though if you go back and look at the data where they based this approval off of, the thyroid cancers were not actually improved. So what I can say here is we have this study, but we really don't have data to support or to say that the response rates are the same or similar or even lower. So right now we have this small randomized study that we're dealing with, important, but yet we do need confirmatory data perhaps in the future. TRK fusions. So these are basket studies that were published for both entrectinib and larotrectinib. And in the green bars and yellow bars, you can see that the responses that were seen with thyroid cancer patients. Again, these can be very dramatic, up to 70 or 80% response or even higher, and sustained responses sometimes not even reached. I have one patient, for example, who's been on this drug for now 5 years, doing beautifully. Here's an example of this lady actually who had larotrectinib. You can see the superior vena cava syndrome that she experienced here on the left side, and now back today she's doing beautifully and back to enjoying her regular quality of life and her grandkids and things that she had been doing prior to her diagnosis. So RET signaling. So on the left we can see these point mutations with the medullary thyroid cancers, and then the fusions that we see with the differentiated thyroid cancers, and the very nice responses we can see in the early studies with thyroid cancer, showing that targeting this one particular RET mutation or fusion does lead to a dramatic response, sustained benefit. And here we see that the overall response rate in the Libretto study and the ARROW study, which looked at pralsetinib, so these direct RET inhibitors, is quite high across the board. Unfortunately, pralsetinib has now been taken off the market because the ARROW study doesn't have confirmatory data like we do with Libretto. So it does not mean the drug did not work and that the side effects were leading to reasons that should be taken off. But nonetheless, it's been taken off, I think, until later data is established. Overall, the side effect profiles are better tolerated than we see with some of these other drugs, though they do have their shares of issues. Durations of responses in the Libretto study has still yet to be defined, though now several years later, we're starting to see patients who are relapsing, but nonetheless, there are a lot of patients who continue on these therapies doing quite well. Immunotherapy for DTC really has not shown any benefit as a single agent. Perhaps those with high mutational burdens do have some benefit, but you can see an overall response rate of really 0%, some sustained or stable disease in about half of the patients. So it's really not recommended that we treat patients with immunotherapy as a standard agent for thyroid cancer, though that may be changing, and I'll show you some data shortly. So kind of putting this all together then, based on the data that I've presented to you, if people come in with, and we find TRK fusions or RET fusions, these differentiated thyroid cancers, it does make sense to start with these directed therapies. The response rates are great, the side effect profiles are there, but they can be, with adjustments, good. And again, we can have durations of response that can go on for many, many months. And again, some patients years. I still have patients from the original studies who are still on the agents and are doing quite well. Based on the randomized large studies that we have, sorafenib, lenvatinib would remain as frontline. Lenvatinib probably is the preferred agent due to the large response rates and the improvement in progression-free survival that's better than sorafenib. However, there can be more issues, I think, with really extreme hypertension and bleeding. So if your patients are more susceptible to bleeding or perhaps having more difficulty with controlling hypertension, sorafenib may be the agent that we should consider starting with up front. But in general, lenvatinib would be the drug of choice. Now we have second-line data from the COSMIC study showing that cabozantinib actually is beneficial after these agents, people fail these agents. And then we probably would consider BRAF treatments with vemurafenib, dabrafenib, or combinations of DT, and then maybe consideration for pembrolizumab in combination with these TKIs that I'll show you data from ITOG, and then if for patients with high mutational burdens. So it kind of is based from stronger data down to this weaker data. So I think we are starting to get a hierarchy of agents established for differentiated thyroid cancers when they're refractory to iodine now, which is really, really good news. We've come a long way. So medullary thyroid cancers, again, a small number of patients develop these cancers. 75% are sporadic. Of those that have the sporadic mutations, there's about 60% or so who have these RET mutations, which is great based on some of the data we've seen earlier with the differentiated thyroid cancers. And then the 25% are hereditary, and most of those, as we all know, harbor these RET mutations. So the treatment of choice is surgery. Obviously, those patients who have these hereditary syndromes, we want to take these young children to surgery right away, to resect them, total thyroid neck dissection, postoperative radiation therapy, a big X there, because radiation does not work for these cancers. We tell people not to do postoperative radiation therapy because when we treat these people with TKIs, cabozantinib, vandetanib, or even these new RET inhibitors, we can get a higher risk of fistula formation, and really there isn't any benefit from that. Doesn't mean to say that you can't use radiation for recurrences or bone metastases involving the spine, but postoperatively, we would not recommend it. Patients who are not resectable, have metastatic disease, we look at targeted therapy, either with the multi-targeted inhibitors that were approved first, and now with these direct inhibitors. So you can see the kinomes here, nicely showing that the salprocatinib and prasetinib have, the direct effect on RET. And based on the blockage of these various mutations, you can see the increased risk of side effects when more are involved. So these pan kinase inhibitors, diarrhea, rash, hypertension, headache, prolonged QT and vandetanib, and GI perforation. So those of you who are taking boards, those are things to remember for these drugs. And then potentially tumor lysis syndrome with prasetinib, but I think that was more common with some of the lung cancer patients. But increased LFTs, hypertension, rash can be issues with salprocatinib and prasetinib. So it's interesting. There are a handful of patients who are really not able to tolerate these medications. So we need to monitor them, just as closely as we monitor those that are the pan kinase inhibitors, because the side effects can be real, but they can be addressed with adjustments to dosage and, sometimes with supportive medications. So these are the first studies with Lenvatinib and Cabozantinib that established the FDA approvals for these drugs. In the Cabozantinib study, we see this broader improvement with progression-free survival because patients on this study had to have disease progression as compared to the Zeta trial. But nonetheless, both agents are now FDA approved, one not over the other. Some of us believe that maybe Cabozantinib provides a little bit better activity. So in those patients who are very aggressive, who don't have the RET mutations, I oftentimes will start with Cabozantinib. People I think who have a more limited performance status or won't be able to tolerate Cabozantinib because of the potential for hand-foot syndrome and some of the extensive hypertension, I will start with Lenvatinib first. But nonetheless, I usually tell patients, you're going to see one, and then you're going to see the other at some point in time. So the efficacy of Selpercatinib in these thyroid cancers, we published this in the New England Journal of Medicine. And again, like with the differentiated thyroid cancers, we see the very nice, robust responses in the primary set and then integrated analysis of those patients who were previously treated with Cabozantinib or Lenvatinib, and again with the RET fusions. And the progression-free survival not yet reached. We're still continuing to follow these patients very closely to help establish that. Pralsetinib, again, I mentioned earlier, is taken off the market. You see very similar results with response rates that are very high, close to 70%, especially in those patients who are naive to multi-targeted kinase inhibitor therapy. And here's an example of a lady who came in with large tumor burden from a medullary thyroid cancer in her liver. We can see within 2 cycles, she's back to almost normal with a normal liver, and her quality of life was vastly improved. In fact, she and her little lady friends make me little baskets for patients in the infusion room. So she's still going quite strong. So these are the benefits that, these drugs really have changed our world in the treatment of medullary thyroid cancer. So kind of moving forward, we're trying to establish, should we start with these targeted therapies or should we start with these multi-targeted inhibitors, first? So this is a study that's ongoing now, randomizing Selpercatinib to kind of dealer's choice between Cabozantinib and Lenvatinib. The study is now in an interim analysis, and I think some of the data may be presented at ESMO this coming fall. And also, can we use Selpercatinib up front? So if we're seeing this benefit from this tumor, can we make surgeries easier or extend progression-free survival or perhaps even cure with these patients? So there's a study of patients who are RET positive, whether they're differentiated or medullary. We treat them up to 7 cycles with Selpercatinib and then take them on to surgery and then following them for disease progression. So this study is ongoing. We have it open at our center. It's through Mark Zaverio and Maria Cabanillas down at MD Anderson as the primary investigators. And then these second generation RET inhibitors are becoming really important. So people develop these solvent fronts where there's stereotactically the receptor is changing. And so they don't find the benefit from Selpercatinib or perhaps Pralsetinib anymore. So LOXO 260 is an agent that's looking to overcome this and also looking at bypass mutations, though we're finding out that the bypass mutations, the development of perhaps BRAF in some cases or our PIK3 are not necessarily providing the benefit with this drug as compared to those patients who develop these rearrangements or these solvent fronts as they're known as. But that still is giving us another opportunity for such patients. So that is good news for those patients with medullary thyroid cancer, that we really may make this really into a more chronic disease for a lot of these people. So moving on to anaplastic thyroid cancer, we know this is the worst of all cancers, though this disease is changing from what we know about it. Again, remember, 50% of cases or so arise from the DTCs, and about 50%, can have these BRAF mutations, probably again arising from these differentiated forms as they become more dedifferentiated into anaplastic. And then again, I always tell our fellows that patients who have squamous cell of thyroid, it is considered an anaplastic variant, and we often treat them similar to head and neck cancers with squamous cells. So this is a results from a basket study that led to, from Anderson, that led to the approval of Dabrafenib and Trametinib in anaplastic thyroid cancer patients who are metastatic, showing response rates when the combination of the BRAF and MEK inhibitor were given together of about 73%. and excellent duration of response. So with a small number of patients, this actually led to an FDA approval because we really don't have any good agents to treat these anaplastics. But again, with these mutations that are seen, we're now seeing much bigger benefits. We can also see them with NTRK fusions and with RET. So again, next generation sequencing for anaplastic, not just to look for BRAF, but those other fusions are important. So what about the use of checkpoint inhibitors? So spartalizumab was a PD-1 inhibitor that's no longer being developed. What was studied in thyroid cancer, but as compared to when we showed you the differentiated thyroid cancers with 0% responses, we see about a 20% response rate with these. And it does show you that PD-L1 expression does make a difference. So when these anaplastics come in, I do check their PD-L1 status. And now Merck is pretty generous that with their program, at least because they're still on patent, that we are able to get the medication, for those folks. So people who do express PD-L1 do have a better chance of responding to checkpoint inhibitor therapy. And then this was data that was presented and then published. It's a small group of people. And those patients who don't have a point mutation, so no RET fusion or NTRK or BRAF point mutation or mutations, that combinations of lenvatinib with pembrolizumab actually can show some benefit here. We can see some nice responses, complete responses in some of these patients that can be sustained. So, Mabel Ryder from the Mayo Clinic, and we were talking, and she, talked at ATA that she believes that, patients who do not have a driver mutation that's known on NGS probably should be treated with combinations of lenvatinib with pembrolizumab. So what about the neoadjuvant setting? So taking this one step further, if people are BRAF positive, we're starting to treat them now based on this study with combinations of dabrafenib, trametinib with pembrolizumab, and then bringing them to surgery, and then afterwards continuing them with radiation and the immunotherapy, and then putting them back on DT with pembrolizumab. And we've actually seen some benefits with these people, and it is potentially possible that we could cure some of these patients. Obviously, we'll need longer follow-up time and completions of the studies to find that where the data falls out. But compared to where we were years ago, we do have opportunities to actually improve the quality of life for such patients. I know I've seen this in my clinic, and some of you probably have as well. So my puppy says, where do we go from here? How do we use immunotherapy perhaps with these targeted agents? So I am a member of the International Thyroid Oncology Group, and we have completed a study that we're still following patients with the data. It has not yet been published, but presented using the combination of lenvatinib with pembrolizumab. So we had two cohorts of patients, those that were naive to any kind of therapy, who were RAI refractory, showed up with progression of disease, and those who had been on, in a second cohort, lenvatinib and progressed on whatever dose they progressed on, then were given pembrolizumab in combination. And what we saw here was that we were hoping to see an improvement in response, because there were some complete responders in the Chamberlain study. We did not see that. We saw very similar partial responses and maybe a minor improvement in stabilization of disease and clinical benefit, but really not a lot of difference in general from the Chamberlain study. And so you can see the 12-month percentage of progression-free survival is around 75%. So this suggests maybe there's a small benefit by adding the two agents in up front. But I think where our money lies is right here in cohort 2, where people who are on lenvatinib for a period of time, and then pembrolizumab was added to their regimen, we see actually responses of about 20% in stabilization disease and 83%. So these are people who are progressing on TKI therapy. So they weren't switched to a different TKI. They were actually given pembrolizumab in combination with lenvatinib, whatever dose they were at. And so I think this is kind of where I think that the money lies. So interestingly, you don't see this in other cancers, and like renal cell cancer, you see benefit up front, where I don't think we're really seeing that. But when we're changing or altering the microenvironment of these tumors and then adding in immunotherapy, I think they are more receptive to a hotter environment with the immunotherapy. So here we're seeing a progression-free survival around 11 months. So these are, again, patients who are progressing. It's a little bit under where the Chamberlain study was. So this could give us an opportunity to continue a patient on frontline therapy with Lenvatinib, with pembrolizumab, before we end up switching to, Cabozantinib or perhaps another targeted therapy regimen. So just a little bit about, the future. We do know that when we block, BRAF and the MEK pathways, we get this uncoupling of CTBP1 and 2, and then upregulation of HER3. So maybe it makes more sense to block, the HER pathway in combination with the BRAF pathway. So here's an example of a patient, interestingly enough, who was on Lenvatinib, then progressed with this lymphangitic spread, as you can see on the right side in December of 2020. This guy was suffering on oxygen, came in, I put him on, after he had progressed on Lenvatinib, I put him on some steroids, and he couldn't get approved for Trametinib for some reason. So I gave him combination dabrafenib and afatinib, so which we use in lung cancer, again, a pan-HER inhibitor. And you can see he came back in the spring and after the holidays and was doing much better. And now here, October 2021, complete response in the neck, and the lungs are much improved. I haven't updated this, but I just saw the gentleman. He continues to have the same response in the lungs. He actually has developed a small met in his iliac crest that I'm radiating. I'm following him with cell-free DNA, so you can see the nice trend upward. And then after radiation, the trend has come downward. So this may offer a better advantage for patients, perhaps compared to the dabrafenib and trametinib. So this is something that, hopefully will be on the docket for a clinical trial in the future. And this is a study we're actually doing at Michigan. It's combinations of cyclophosphamide and rapamycin. So I kind of stole this regimen from our sarcoma folks years ago when I knew the mTOR pathway was active in these cancers. And we can actually see that there are some patients who continue on treatment with these mTOR inhibitors and then blocking the cell cycle with cyclophosphamide. So the study is ongoing. So it could offer an opportunity for patients who do not have the ability to receive a TKI therapy for various reasons. So kind of putting this all together, then the median time to symptomatic progression is about 5 years. So we can safely, tell some of these people that, we can watch you, and we're going to watch you closely, and based on intervals of 3, 6 months, a year, perhaps on your thyroid globulin levels, your progression on your imaging studies, and that you don't necessarily need treatment right away. Next generation sequencing is a must, as we mentioned. The NCRAC RET fusions and possibly BRAF considered for upfront therapy in various patients. And then sequencing is becoming established. As I mentioned, we have the Lenvatinib and sorafenib, which are the largest randomized studies that were well conducted and probably, again, should be considered as frontline therapy. Cabozantinib, again, with excellent data, second line therapy. And then checkpoint inhibitor therapy may play a role, obviously in anaplastic thyroid cancer, but also with those differentiated thyroid cancers, in particular those who failed TKI therapy. So sequencing of RET inhibitors is becoming established. Though it probably will be that the direct RET inhibitors will most likely be the agents we start with. And finally, inhibiting BRAF signaling, down regulating HER3 may be a benefit over actually just blocking the MEK and the BRAF pathway. So with that, I'd like to thank our oncology program here at Michigan and the Punya Foundation, for which I have a endowed professorship from Mr. Wigington and his family, because I took care of his wife at Michigan years ago. So with that, I don't know what time it is here. It's 10 minutes left, I guess. So I will be happy to take questions, or Margaret, if you want to make comments. Thank you very much for allowing me to step up to the plate and give you kind of an overview of where we're at with the medical advances in thyroid cancers.
Frank, let me just tell you, this was spectacular, and I cannot thank you enough for stepping in short notice to deliver this really magnificent talk. I feel like I have just gone through a fellowship in medical oncology, and where I can get, as well as all of our listeners can get their diplomas. We're going to be sending you a request for that. Let me
Okay.
just ask you,
Yeah.
let me just ask you, the history of cancer, systemic cancer therapy, and this is from, has always been combination therapy in an effort to reduce the risk of developing resistance. Is this a paradigm shift here? And some of this really dovetails into the specific study that NIFA was going to be presenting this morning, but maybe if you could just comment on that from a philosophical perspective here.
Yeah. I mean, it's interesting, like, in her paper, she talks about this kind of, onco approaching, addiction, like in why responses, in melanomas are higher, even though people are developing these variants or different mutations. They still have this main driver, pathway. We're not necessarily seeing that so much in the thyroid cancers per se. And I guess the question is, what you're asking is, are developing resistance, I suppose, by, perhaps maybe watching these people and then treating, later, I think. Is that kind of what you're asking, Mark, too? I want to make sure.
No, I think the overarching philosophy from if you go, going back in history, is that you can prevent resistance by attacking a cancer in multiple directions here.
Oh, right.
So I'm wondering if that is if the approach here, and certainly, there was no superiority of dabrafenib plus trametinib over singlet therapy in radioiodine-refractory.
Mhm.
Is this a change in the philosophy from a medical oncology perspective?
Yeah, I mean, yes, I think the answer is yes. That before, when we gave cytotoxic chemotherapy, was just trying to knock out cells by inhibiting or breaking apart the DNA. And so I think people have realized where the money is by going after particular targets. So, I mean, her study, just to get back to that study, DT versus D, wasn't powered to show a difference in progression-free survival. I think they were hoping to see a more robust response rate with the D plus T versus D, which they necessarily didn't. And again, that could have to do with that whole, oncogenic, addiction that I had mentioned earlier, or perhaps because we're not completely blocking the pathway, such as the HER pathway. But to answer that question is, going after these different targets, does that make a difference? Meaning that if people progress, could you consider adding on something else? And yes, the answer is yes. The question is, how tolerable are these things? I know in my own clinical practice, I do that, so if people, we find they develop a bypass mutation with a PIK3, we will add on a PIK3 kinase inhibitor in combination with these drugs. So following the oncogenic targets, I think, does make sense, especially for these tumors that oftentimes progress more slowly, so that their turnover of the cells is quick unless they become more poorly differentiated. Interestingly, there's some data from the Mayo Clinic Maples group where they talked about combinations of carboplatin and pemetrexed for these people who become more anaplastic-like. But again, we rarely use cytotoxic chemotherapies in these drugs. So I think these kind of cancers, these vascular tumors, and we see this in renal cell, we see this in GIST cancers, that we go after these targets, I think does make the most sense. I think the idea about blocking, the HER, like I showed in that one patient, probably does make more sense. The question is, people who are on D plus T, if they're progressing, should we add in, if we had it available, pan-HER inhibitor to see if we can even, overcome the resistance, to those drugs, would be an interesting question. Something I haven't done yet. I think the other thing too is that I mentioned with that ITOG study about the addition of immunotherapy, we are altering the microenvironment of these tumors by long duration of exposure to these targeted therapies that adding in immunotherapy, we can stop the growth of the drug. And that's what we tell patients, is that we're not curing your cancer. We're trying to delay the progression of your cancer. So none of these targeted therapies really have shown that we're curing cancer. It's really that, can we slow, the progression of the cancer, and can they tolerate it? So I think that's where we're at. And so instead of just, my opinion, you're trying to get as much bang for your buck out of the one target. So that's why I would say, the immunotherapy added on to those TKIs, and then consider switching, only when there's true progression after that. Does that help answer that question?
Yeah, tremendously. But so let me ask you, before I ask Dr. Brandwein for questions here, is this, when you do get a very favorable response in radioiodine-refractory tumors with either multi-kinase or targeted therapy, it's got to be incredibly tempting to retry radioiodine to see if we have redifferentiated. So where does that sit in your mind, and how often do you actually do that?
Yeah, that's a good question. And so the data, Anderson has some data, especially in their BRAF patients, where it's about 30% of people had some benefit. It's not an established standard, Mark, so it's not something that every center does. We would consider it only for those people who have responded to RAI up front, which means that, there aren't those people you give the iodine to and then just no uptake. It's like, you're not going to make those patients better by giving drugs. But people have had a response to that and then go on to get the drugs and then to go back and check, is how we do it. And I think that's where it's at, because there really isn't good data yet to support that's what should be done. And because there isn't good data, the ITOG is looking to have everybody kind of collectively pool their data together and just their own experiences to see if we can see some kind of, or develop some kind of guideline for that. So I would say right now, I don't think it's wrong to consider, but I would only use it in patients who have shown me that they've had some response to radioactive iodine in the past. And now you give them, they're progressing, you give them targeted therapy, and then you go back and repeat the scan. But those patients, again, who are kind of progressing through all this, they're not going to attain any kind of benefit from that because we've never seen it.
Margie, did you have questions or comments?
So, can you hear me?
Yes.
Yes.
Yeah, good morning. So Frank, let me just echo what Mark said. That you just delivered a terrific lecture. So I thank you very much. I can't talk too much about this, and I also want to say you had me at Dostoevsky. So all happy families are alike and all unhappy families are different in their own way.
No way.
So, right. So, as pathologists, we're in the prediction business. And in general, as a head and neck pathologist, thyroid cancer blew my mind because I was used to the idea that all primary tumors can predict the outcome. And you can say that with squamous cell carcinoma, with salivary tumors, with a pretty good accuracy. But with thyroid, just by looking at the primary tumor, it's amazed me how much you can't make a prediction. Yet, of course, that's why the ATA came up with the ATA ROR. So if you have a whole picture at presentation, you have, and you're still dealing in the realm of a differentiated thyroid cancer, in a way, you don't need a pathologist to make a further individual prediction based on just the primary, because you have the primary and then the lymph node status as a major predictor. And yet, there are things that from the MSK group, from Ronnie's MSK group, we can predict certain outcomes, just from the primary. And of course, necrosis and high mitotic rate, is a huge predictor. Occasionally, we have patients. So all of your fabulous lectures given in the context of metastatic disease. And so patients will present with the metastasis already. And that's what's driving the treatment and everything else. Occasionally, you see tumors that present with metastasis where there's no there's no established feature for malignancy within the primary. This was actually mentioned once by Tuttle in one of our tumor boards, and he just went right past it, like, yeah, occasionally we see that. And so we have a case like that, which is kind of astounding, where, the patient has metastasis, but if you look at the primary, well, it's not even immediately, obvious that this would have undergone this course, So how often do you see cases like that?
It's interesting. We do occasionally see those. And it's so interesting, Margie. I don't know that, I'll be honest, like the surgeons and the endocrinologists are kind of afraid to look because, I've always been told it's just like, don't get this stuff because all it's going to do is upset the patient and we don't know what, to do with it. But I would argue in kind of the stuff that, I support, Maria and Mark down from Anderson about, and even there is another study too that, Lori's involved with at Mass General and that group about doing like Lenvatinib up front to see if you can, downsize these tumors, which may have a benefit, for the effect of, distant mets. I don't know that we know that per se, but, yeah, it's interesting because, it's interesting as medical oncologists, they don't ever consult us at the beginning as much as I'd like them to. Now, the ENT surgeons are better. They'll come and say, I got this really big tumor, for example, and I had a lady who had this BRAF, and interesting, her husband was having a valve replacement, and he was so sick that she goes, I don't want to have surgery now, and she's gonna have to lose her voice box. So Dr. Casper called me and I said, sure, let's give her, paying her therapy. And I did. Her clinical disease didn't change much. And Mark Zaffario always say that. He said, well, unless it's kind of becoming more, aggressive or differentiated, I don't know if you're going to see the response. And clinically, she didn't really improve that much, maybe a little. She did not, see radiographic change. But at surgery, interesting, Margie, that the surgeon kept calling me. He goes like, the path when they did the testing in the operating room was negative, and she had one little involvement in the tracheoesophageal groove, which allowed her to keep her voice box. So I do think there is room for that with these, I want to say, more aggressive tumors, to look at the sequence, to look at the genetics or the pathology behind this, though that I think uniformly has not been the standard at most centers.
Right. I have another question. If we have just a moment, you mentioned something about NTRK in ATC. And so we don't, we do rapid BRAF, we don't do rapid NTRK. How often do you see that?
So, boy, it's rare though. It's probably in the order of like 5% or less. But I have 3 patients who have anaplastic in my practice who all have NTRK, who've responded beautifully, to therapy. One had this elevation of liver function test, so I've been dealing with that. But so what typically do is we do the rapid BRAF, and then if that's negative, I will go to my pathologist and ask them to do the RNA and DNA, next generation sequencing to look for these RET and these NTRK, fusions that exist, because if they're there, we will treat them with those other agents, and I've had very good success.
Okay, so for 5%, it doesn't make sense to because time is of the essence with these ATCs. Right.
Correct.
So, but it doesn't make sense to also do rapid NTRK testing at the same time.
I don't think so. No. I only go after that.
Good to know.
BRAF is negative. Yeah.
Right. Good to know.
So we are up against the 9 o'clock hour. The most pressing question of the morning had to do with the Sesame Street references in your family photo, which we did not get to, but that may be, that will certainly be a topic for a future lecture here.
Absolutely.
I can't thank you enough, Margie. Thank you for jumping in here. And we certainly wish Dr. Basadi well, and she will undoubtedly be back for to deliver that talk once again. Everybody, thank you for joining us. Everybody stay safe, and look forward to seeing you next Friday. Thanks again.